Hello everyone, today we'll speak about congenital heart defects. So just let me do the eraser. So congenital heart defects are structural abnormalities of the heart and the great vessels that will be present at birth. So we will classify it to two types, acyanotic and cyanotic. So acyanotic uh, cardiac heart defects are left to right shunts. So we will have in this one, we will have an increased pulmonary blood flow and without any significant cyanosis, and this will lead to congestive heart failure and pulmonary hypertension. So we will have the blood draws from the left side to the right side. That's why it's called left to right shunts. So for the second type, we have the cyanotic. Here we will have a mixing of the deoxygenated and oxygenated blood, leading to a systemic cyanosis, often present with blue baby syndrome and require early surgical intervention because he's not getting enough blood. We will have cyanosis. So as we can see, this time the blood will go from right to left. That's why it's called right to left shunts. So for the cyanotic asymptotic, the left to right shunts will have four main types. So let's get to know them. The first one is atrial septal defect. As we can see, it's present between the atrium. We will have this is the septum between them. We will have a defect here that will lead the blood to draw from the left to the right side. So it have actually subtypes. First one is osteum secundum. Is the most common type. It defect in the middle of the atrial septum, as we can see. In the middle of the atrial septum, we will have a defect. Then we have osteum primum. It's located in the lower part of the atrium septum, as we can see. Where is it? This one. This is the lower part of the septum. This picture is not that clear, to be honest, but it's here and is associated with the atrioventricular valve abnormalities. So it's here. And the sinus venosus is near the entry of the superior and inferior vena cava. This is the superior and inferior vena cava. So we have the defects here. Then we have the coronary sinus. It's rare, but it defect in the wall of the coronary sinus. So it's here. So another picture. This is the secundum. This is the primum. This is the venosus, and this one is the coronary sinus. So for the pathophysiology, it's left to right shunting and increase the pulmonary blood flow over time, potentially causing right heart volume overload. In the auscultation, we will hear a soft systolic ejection murmur. So let's hear it. Oh, I need to turn off my laser. So this was the systolic ejection murmur. For the diagnostics, we will need an ECG, chest X-ray, and echocardiogram. In the ECG, we will see a right bundle branch block and right atrial enlargement. In the chest X-ray, we will see enlargement of the right heart border because we will have a right atrial enlargement, right atrium hypertrophy, and an increase in the pulmonary vascular markings. In the echocardiogram, it will confirm the size and the location of the defect, and we will see it actually. For the treatment, the small defects will close spontaneously, while the larger defects may need surgical repair or percutaneous device closure. So this is the anatomy of the echocardiogram if you didn't know about it before. This is the left ventricle, right atrium, and left atrium. So here we have what do you call it? Atrial septum. So as we can see, between the left atrium and the right atrium, we have a septum, and the blood is moving from the left to right if we have the video, but I don't think this is a video. So for the atrial enlargement, just because this is very general information, I won't be able to explain all the ECGs today. So we will see in the right atrial enlargement, in the second lead, we will see a P called P pulmonary, which is a very high P than normal. And if we have a left atrial arrangement, just for your knowledge, we have a peak called P mitrale, which is usually like two mountains. And in the V1, we can see it very clearly. The first like, let's say, mountain in the P is the right, and the second one is the left. So if they are not the same size, so the pressure from the atriums are different. So as we can see, P pulmonary more than the normal size, so it's right atrial enlargement. The second one is ventricular septal defect. This time we'll have a defect in the ventricles. We will have four types. The membranous is located near the membrane center, muscular, like in the upper part. The muscular in the muscular portion, maybe multiple. It's in the inferior part. Inlet near the thoracic valve, and outlet is near the outflow tract. So just for a simple, this is the membranous, and this one is the, what do you call, the muscular. So here we will have a left to right shunt as well. That will increase the pulmonary circulation, and we will have a risk of pulmonary hypertension. In the auscultation, we will hear a pansystolic murmur, best heard in the lower, in the left lower sternal border. So let's hear it. Amazing, the video is not opening.
Әкең екеуің әбден шаршаттыңдар мені.
Tamam daha kaçıp aldım bak. Bırak olsun bize tan kaldı.
Uh, I hope you'll forgive me. I won't delete that by editing because I'm tired. So as you can see, we won't just hear it in the ventricular defect. We can hear it in the tricuspid regurgitation and mitral regurgitation, and as well as in the ventricular septal defect. So now we heard it. I think it's easy, very easy to detect. Then for the ECG, we'll show a left ventricular hypertrophy, and the chest X-ray will show a cardiomegaly and increased pulmonary vascularity. The echocardiogram is the most best one. You can see the location, the size, and if it's present or not. And actually, I have a video this time, so let's see it. So this is very beautiful. So this is the left atrium, left ventricle, right ventricle, and uh, this should be the right atrium. So as we can see, this is the ventricular septal defect. We should locate that the, what you call it, the valves, and if there's any opening other than the valve, so it is the septum. As you can see, this is the septum. Hopefully we get a blood view as well. Yes, let's go back to here. As you can see, the blood is flowing from it, not in the arteries, and going out from the left side to the right side. See? This is the best video, the best thing. Look, look at the blood, how it's flowing from the left ventricle to the right ventricle. This is not correct, so we know that it's here. And from our knowledge, here will be the muscular, so this one is probably perimembranous. This is actual pyramid banners. I didn't see that, I swear. Just my diagnostic power. So, for the wait, yes, this is the echo. For the treatment, the small one can close spontaneously, but the large one may require surgical or device closure. So, for the cardio left ventricular hypertrophy, we will have a very high QRS complex in the V1, V2, V5, V6. As we can see, it's larger than normal. So as we can see here, we can see very clear that we have a left ventricular hypertrophy. The ventricle of the heart is very large. Then we will have another condition called ductus arteriosus. So usually when we are infants in like in the gestation period, we will have this connection between the aorta and the pulmonary artery. It's connected between them because the lungs is not working at that time, so we don't need the blood to go to the lungs. So we need this the the ducts between artery and the pulmonary. This should be closed before we get born or when we get born. So in some cases it stays. So this is the case that we will have ductus arteriosus. So persistent or the fetal ductus arteriosus, it will stay, leading to a continuous left to right shunt. In the auscultation, we will hear a machine-like murmur perceived in the left infraclavicular area. Since there is no video, I didn't find a good one, but you can find it, I'm sure. For the diagnosis, in the X-ray, we will see a enlarged left atrium. We will have a left atrium hypertrophy and ventricle with an increased pulmonary vascular markings. We will see that, I'm sure. For the echo, it will confirm the presence. Actually, I really like the echo of the ductus arteriosus. It's really interesting and easy. See this thing. See how the blood is flowing in it, and the ductus arteriosus. Just save this movement, and you will be alright. Maybe now for the first video, you will say, oh, what the hell is this? But just wait. Now see it again, and we'll see the other video. I'm sure you'll understand it. Look at the blood. Okay, you see the other video? I'm sure you'll learn it. Yeah, this is really clear, to be honest. I hope you got it. For the treatment, we can go with a pharmacological closure with NSAIDs, like for example ibuprofen, and the preterm infants. Then a surgical ligation or catheter-based closure if pharmacologic therapy fails. So as we can see here, we can see the left atrium enlargement. To be honest, this X-ray is not conformative for the patent ductus arteriosus because this X-ray looks like another condition that we'll learn about it later, but it's a sign. So atrioventricular septal defect is the last one. So actually, we will have a septal defect between the atria and the ventricles, but it could be different. We'll have subtypes of it. So this is the normal heart. Everything is good. The partial, we will have a partial opening uh, between them, and sometimes it's just in the atria or the ventricles. Transitional is around the valves, but it's still small, and the complete is a disaster. It's a very big opening, as we can see here. For the pathophysiology, we have abnormal development of the endocardial cushions leading to a defect in the AV junction. In the auscultation, we will hear a whole static murmur, which is the same sound that we'll hear in the ventricular defect. In the ECG, we will show a common atrioventricular condition pattern. So actually, we will go to the echocardiography, which is important in the knowing the anatomy and the kind of it, then planning the repair. The treatment is usually surgical repair is necessary in some cases. Then we will move to the cyanotic cardiac heart defects, such as the right to left shunt this time. So first of all, we have the teratology of fallout, the boot-shaped heart. So here we will have four defects in the heart. The first one is pulmonary stenosis, the right ventricular hypertrophy, overriding aorta, and ventricular septal defect. So it's a combination of cause that will reduce the pulmonary blood flow and lead to right to left shunt. The auscultation will hear a harsh systolic ejection murmur due to the pulmonary stenosis. The diagnostic, this time the X-ray is the most important one. So for the ECG, we see the right ventricular hypertrophy. For the X-ray, we'll see a boot-shaped heart. It's very common, very known. Everyone know about it. The echocardiogram confirms the anatomy and the degree. For the treatment, early surgical repair, we will do a surgical repair most likely. So this is the boot-shaped heart, as we can see. Tritology of a lot. Boot-shaped heart again. It's really good diagnostic way for it. Then we have the transposition of the great arteries. We will have an aorta instead of the pulmonary artery and pulmonary artery instead of the aorta. And this will lead to a mix. So the aorta arises from the right ventricle and the pulmonary artery from the left ventricle, which is will be a parallel circulations. So we will have like S2 and minimal murmurs. The ECG will show right ventricular hypertrophy. The ECG will see this time egg-shaped heart. The echo is essential for confirming the diagnosis. The treatment, first of all, we do a administration of prostaglandin to maintain the ductus arteriosus patency. Then the arterial switch operation is the definitive surgical treatment, and we should do it quickly because we have a cyanosis and maybe some irreversible damage. So this looks like a heart in it. As you can see, this is egg-shaped heart. Yes, egg-shaped heart. This is the heart. It looks like an egg. Then we will have tricuspid atresia. So we will have an underdeveloped or absent tricuspid valve. So in the auscultation, we will hear a allostatic murmur again. This is the third time we have it. For the diagnostic, in the ECG, we'll have left axis divation, dominant left ventricle forces. Chest X-ray, we will have reduced pulmonary vascularity and cardiomegaly. The echocardiogram will reveal the absence of the tricuspid valve and the associated defects. This is the most important thing. I really love the echocardiogram for this one. Look, look, here the valve is not open, it is underdeveloped or closed in some cases. As you can see here, here it's closed to be honest. The mitral valve is working, but look at the tricuspid closed. This is really beautiful. I don't mean the condition, I mean the cap. So for the treatment stage, surgical operation will be our best thing. We don't need to know the details. We are still students, not surgeons. So for then we'll have a total anomalous pulmonary venous artery. So we'll have actually subtext for this one. We will have, yes, I have some pictures. So first of all, the supracardiac. We'll have pulmonary veins drain above the heart into the superior vena cava. So superior cardiac, as we can see, pulmonary veins. This is the pulmonary vein that will drain to the superior vena cava, for example, as we can see, pulmonary vein that will go to the superior vena cava. Then this time we will have pulmonary veins that drain into right atrium or coronary sinus, as we can see. It's a pulmonary vein that's draining to the right atrium. Infracardiac drain to the portal vein, for example, or inferior vena cava, as we can see, it's also draining there. So pulmonary veins will drain into the systemic venous circulation instead of the left atrium, causing mixing of oxygenated and deoxygenated blood. In the auscultation, this will may reveal a soft systolic murmur. For the diagnostics, ECG may show right atrial enlargement. And for the chest X-ray, we will see a snowman or figure 8, which is a very clear sign for it. Echocardiography will confirm the diagnosis and the treatment is surgical repair. As we can see, it looks like a snowman to be honest. Not so much with this picture, but it's like a snowman to be honest, just not a very clear one. This one is good, as we can see. Snowman. Again, snowman. And actually, this is everything for today's lecture. I hope you found this useful. I tried my best to include a lot of things in it. I hope you enjoyed it, you found it useful. If you have any tips about my presenting or anything, please leave it in the comments. Thank you so much for listening. You have a great day. Goodbye.